I'm here with Greg Moloney. Greg, we've spoken in the past a little bit preliminarily about this absolutely brilliant work that you're doing. And by the way, I want to congratulate you on winning the Troutman Award from the Cornea Society for this work, for this paper.
Thank you.
You have studied primary desmetorrhexis, which is to remove the endothelium without then performing any sort of graft. There's no allographic tissue. And this is something that has been discussed with fervor recently. But what you've done is you've described employing a ROCK inhibitor to aid in the mobilization of the peripheral endothelial cells. First of all, talk me through this, and then fill me in on what's been going on since you and I spoke last.
Yeah, thank you very much for the opportunity to talk again. But no, I think when we last spoke, I think what we knew about removing Descemet's membrane and not implanting a graft was that if you do that in Fuchs dystrophy, in a certain type of Fuchs patient who has central guttata, mainly affecting the vision, they had about an 80% chance to heal on their own. That was what we found and others found as well. But that healing time could be variable, and there was obviously that percentage of patients who wouldn't respond or wouldn't clear their cornea. Based on the basic science work from the group in Kyoto, which is Naoki Okamura, Noriko Koizumi, and Shigeru Kinoshita, we attempted in our patients who were failing that initial surgery in our first surgical trial to rescue the non-clearing corneas with topical ROCK inhibitor therapy, and we were successful in doing that. Based on those results, we have moved into a second phase of a clinical trial where patients are receiving a topical ROCK kinase inhibitor immediately after surgery, and what we're seeing now is quite surprising and exciting in those early results.
So let's just walk this topic back a little bit,
Sure.
because although it's not novel to me now that you have spoken a couple times with you, it is novel to a lot of our viewers. First of all, in primary desmetorrhexis, there is a repopulation of endothelial cells in the area where the endothelium has been stripped. Is this simply a migration of extant endothelial cells from the peripheral cornea, which has not been stripped, or is there mitosis going on? Are there new cells?
We in our initial studies of this surgery, we certainly can find, and you can find mitotic figures in the peripheral cornea. But I guess the final value that counts is what is the total peripheral corneal cell count doing, or the total corneal cell count doing in the center and in the periphery. And from this analysis of that cell count data, the cell counts go down. So it's mainly, we believe, a migration that is producing that repopulation of the central endothelial cells. The human cornea probably has some mitotic ability, particularly in the periphery and particularly at a younger age, but in most patients we are relying on a population that exists to migrate and repopulate the central cornea.
What does ROCK kinase have to do with the endothelium?
So, I mean, the ROCK kinase is an enzyme that was discovered in 1996. We, as ophthalmologists, we're late to the study of this and what it can do for us in the body. So it has cellular effects throughout the body and in many different organs and many different cells. What we believe, or how it relates to the eye, is that it's an essential, or inhibition of ROCK kinase is an essential function of neural crest migration during embryogenesis. And the most consistent effect we see of ROCK kinase inhibition in the eye is a morphologic change of cells into a more mesenchymal phenotype that's more capable of moving, of migrating. And we believe that is the main effect that we're utilizing in this surgery, is to push those cells into a more mobile form, so that they can overcome whatever local inhibitory factors exist and cover over that cell defect.
Okay, I have 3 questions, but I intend for them to be my last questions anyway.
Sure.
Okay, number 1, what is your treatment protocol? Okay. Number 2, what are the pathologies that you're treating? Is it just Fuchs, or is it pseudophakic pulse keratopathy and stuff like that? High drops maybe. And number three, what have your results been? If you can share them with me.
Sure. I think we had initial great enthusiasm that topical rho kinase inhibition would salvage the cornea in lots of the situations that you're describing. Our clinical experience that's been borne out is that's possibly not the case, and we don't have great hope that in the pseudophakic bullous case, with a existing low cell count, that you're not going to salvage that cornea with the use of topical rho kinase inhibitor alone. Its main utility appears to be if there's been an endothelial defect created, let's say through our surgery where we deliberately remove Guettada, or for instance even in cataract surgery if there's an unintentional touching of the endothelium. That topical rho kinase inhibitor is useful for accelerating the healing in that circumstance. It has probable other cellular effects that are more difficult to measure and are going to take more science for us to properly answer. But what we can say for sure is that if you compare time to healing without a rho kinase inhibitor in our first study and time to healing with the rho kinase inhibitor in our second study, the mean time to healing in the first trial was 13 weeks with no help from a rho kinase inhibitor, and in the second study it was 4.3 weeks.
It's a tremendous difference. Yeah, and sorry, your treatment protocol. What's the regimen? Do you start it prior to surgery or just after surgery? And
just after surgery, and the initial dose we based and we designed our second phase study around was based on basic science from the Kyoto group, which suggested a dosing of 6 times a day. What we've seen now, I think that dosage needs to be analysed, and we've done a lot of safety data on the use of that drug. We're using it. Patients are needing it for a little longer than we at first realised. So I think the correct dosage is going to be examined and probably brought down from that. I think that's still under debate right now in meetings happening even today. But we have seen what we've learned about the dosing is really 2 things. It's probably necessary at higher dosing than for use in glaucoma, which is a BD dosing for the agent we're using, which is Repopulation. But perhaps 6 times a day might be too much. I think 4 times a day would be a good next dosing schedule to examine. But the other thing we're seeing is that a tapered release of the drug is probably also necessary. Some patients, when we stop the drug, are having a relapse of edema.
Oh, that's so interesting.
Yeah. We have so far no explanation for that.
Yeah, I was going to say it's not that all the little cells are then scattering back out to the periphery. It's clearly multimodal.
Yeah, so it can only be, we assume, a recurrence of a problem with the barrier function or the pump function of the endothelium, and we're yet to determine which of those 2 really it is.
Yeah, absolutely fascinating. Yeah. Greg, I want to thank you very much for updating me on this, for sharing this wonderful work. Congratulations once more, and I hope that this is a trend, and that at future meetings that you and I get to talk again. And as always, I want to thank you for the generosity of your time.
Thank you. I must also add, in every talk I give on this, I try to acknowledge the Sydney Eye Hospital Foundation, which has funded all of our work into this and made all of these findings possible.